Good morning. It's nice to have you here with us. We are also going to have I think a larger audience taking advantage of the live webcast, and we will try to stay pretty much on time because of that. So what I'm going to do is to start off by giving you just a brief welcome and overview, talk a little bit about the Standing Committee on Childhood Obesity Prevention, and then some background about health disparities and health equity to put today's deliberations in a broader context. And then I'll finish by reviewing the format, the approach and format to this workshop. Just by way of opening, I think the task that we have today is to generate ideas about potential future research, policy, and action in areas that could lead to equity in opportunities to achieve a healthy weight, which is the title of the workshop. And I think that your presence here and listening on the web is really a commitment to being a part of the solution. We will not develop recommendations as a workshop like the consensus studies do, but the presentations and commentary will be summarized in a workshop report that pulls together the highlights of what we talk about today. And it's definitely going to be we're talking about. We've tried to make this interactive in terms of the format, which I'll go over. And the webcast will be archived on the IOM website so that people can refer back to it over time. So if I can. I'll start off by introducing the members of the Standing Committee. The list of names and affiliations is here, and also the bios of the speakers and full affiliations of the committee members are in the materials that you received. Several of the Standing Committee members are here with us today, and you may want to stand up and wave or something. Celeste Clark, Patricia Crawford, Bill Dietz, Bill Purcell, Jim Salas, Eduardo Sanchez, Mary Story, Joe Thompson, and Ellen Wartella. And I would, did I miss anyone from the committee who's here? Oh, there's a lot of us. Okay. Oh, Christina Economos, Adam Janowski, and who else? Leanne Birch. Oh, this is wonderful. And Debbie Chang, yeah. And Russ Pate. Okay, so this list is just about everybody's here. That's wonderful. I think I put this list together before we actually knew who all was going to attend. So that's really great. So most of the committee members are here. I would especially like to acknowledge the members of the committee who were on the planning committee for this workshop: Celeste Clark, Patricia Crawford, Chris Economos, Jim Salas, and Ellen Wartella contributed to the planning of the workshop along with my own participation. The Standing Committee was formed to really bring awareness to the urgency of accelerating progress in preventing obesity and sustaining the progress that we're making. It's been a focal point for discussions on policy-relevant priorities with a broad range of audiences, and we've provided guidance on topics for consensus studies, workshops, and public briefings. And so this is one of our workshops. It's actually our last workshop. The staff who've been working with us on the committee, it's changed over time somewhat, but Lynn Parker has been the study director for and the main staff person for the committee. She's a scholar at the Institute of Medicine. And we also have the assistance of Heather Briner, Sarah Ziegenhorn, and Sarah Siegel, and they're here, and you'll see them helping out with this particular workshop. And I'd also like to acknowledge the sponsor, the Robert Wood Johnson Foundation, and Tina Coe, who's here. Acknowledge her, who's the representative. She's our program officer from the foundation. Tina, you're too shy to stand up and read. Okay. So you might have noticed on our list of committee members that Antoinette Yancy was listed as deceased. Tony, as she was known by everyone, died on the 23rd of April of this year, just really recently. And we will really miss her and wanted to dedicate this workshop to her because, especially this workshop, it is so close to what she valued. She was a champion for the issue of health disparities, research, action, 6'2" or 3", and not shy about getting in your face to tell you that you needed to pay more attention to the disparities issues. And a professor at UCLA, a legacy of a lot of students, projects that are still ongoing. There was a National Instant Recess Day in her honor. She invented this concept, instant recess, of short activity breaks that could be done anywhere, anytime, in any clothing, by anyone of any size. And she's known for that, and I've just put a couple of her key articles related to disparities that on the slide here, and some of the work and concepts from those articles will surely be reflected in this workshop. I also have this little note, the poet of public health, and I think you have received the obituary that I wrote for the American Journal of Preventive Medicine, which is called Our Poet Has Left the Stage. Tony was, among other things, besides being an athlete and a former fashion model, she wrote poetry, and you know, kind of way before we really began to use narrative as a powerful way of telling stories about public health. Tony was writing poetry about public health issues and published several of them in the American Journal of Preventive Medicine. So we will dedicate the workshop to her, and as part of that, we will use an active applause just so that we get physical activity. So whenever you feel like applauding, you can stand up. You have permission to get out of your seats and stand up to applause, sometimes also called a standing ovation, which makes the speakers feel good during the workshop. So to continue with some of the accomplishments of the Standing Committee, this is just a review of workshops that we've held over time. You may have attended some of those, and there's a blank for the cover of this workshop, which will be published in the same type of report. Consensus reports on childhood obesity prevention have been issued by the IOM since before the Standing Committee was formed. The first report in 2005, Preventing Childhood Obesity, Health and the Balance, was the sort of landmark beginning of the IOM's really serious focus on this area. And then there were two other reports, including one on food marketing to children and youth. But the Standing Committee, formed in 2008, has identified topics, actions for local governments, evidence issues of Bridging the Gap and obesity prevention report, early childhood obesity prevention policies. The one that is the context for our work, our deliberations at this workshop, Accelerating Progress in Obesity Prevention, which was issued about a year ago. And since that time, fitness measures and health outcomes in youth, Educating the Student Body, which has just come out, I think that's really a cute name, last month. So this committee has been very productive. You hear me talking like past tense because this is actually the last workshop of the committee, and we will be phased out at the end of this, after this meeting. But the good news is that a new phase of IOM focus on obesity solutions is going to enter as we depart as a mechanism for thinking about these issues. The IOM is creating a roundtable on obesity solutions, which will engage leadership from a much broader set of sectors. They've been mostly academics on the standing committee, but this will engage leadership from public health, healthcare, industry, government, philanthropy, nonprofit organizations, the financial sector, and academia, which I think is very fitting. When we're talking about solutions, we can't only talk to ourselves as academics. We have to talk to people who actually have the access and the authority and the resources to create the kind of solutions we need in the broader society. So this roundtable will keep the dialogue going, and you'll be hearing more about that in the future. So now I'd like to turn to the substance of the issues today, and I'm really pleased that we're able to focus on the topic of disparities at a workshop all by itself, not the last session or the afterthought, or oh yes, don't forget about the disparities issues. This workshop is to really put the spotlight on disparities issues. I'm going to show you just the 3 CDC maps that illustrate the fact that obesity is more prevalent in Black and Hispanic populations compared to the white population. So this is these are the colors, with the darker colors showing 35% or more of the state's population being obese, and this is the adult population, and this is what the map looks like for the Black population, with the darker colors meaning more obesity, and this is what it looks like for the Hispanic population. So without showing you a lot of data, because I don't want to take too much time on the problem, because we're here to talk about solutions, but Black and Hispanic populations, for which there are a lot more data, adults and children in those populations, but also American Indians, Pacific Islanders, the Native Hawaiian population, and the Asian American population as an ethnic group is usually not included on the list of excess risk of obesity, and that's in part because the way we measure obesity underestimates the risk that might occur with excess body fatness at lower BMI levels. So I think we should look generally at any population that might have higher risks by the current definitions, or where we want to avoid risk developing in that population. We also consider some other issues and disparities, which I will review in the next couple of slides. So what are disparities, and what do we mean by disparities? This is a part of a larger picture, and it's not new, but finding solutions will be new because we've been talking about disparities for quite some time. For definitions, I like to use the conceptualization of disparities that came from Healthy People 2020, and was written up by a subcommittee headed by Paula Braveman and some other members of the Healthy People 2020 Advisory Committee, and a subcommittee that we created to look specifically at disparities in health equity. So you notice that the title of the workshop uses equity, and this is explaining why. So health equity can be defined as the principle underlying the commitment to reduce disparities. So we want to reduce disparities because they create inequities. One way of thinking about it is social justice in health, because the definition of disparities that we are recommending and using in the public health system is not just any health difference, it's differences that are associated with systematic disadvantages for some populations. So disparities are really the metrics for assessing health equity, and they could be disparities in outcomes or disparities in the determinants. So I said that it's not just any differences, and this is something where we've been, because it feels somewhat political and people want to talk about differences, and not disparities or not social justice. But in fact, disparities really implies that there's some unfairness in the fact that people have worse health outcomes or more determinants of risk. So this is the definition. Health disparities are, I paraphrase, are systematic, plausibly avoidable health differences that adversely affect socially disadvantaged groups. Now, the list of socially disadvantaged groups that are recognized by the NIH or the Public Health Service is not as long as the list I'm going to show you now, but I think the point is that the principle is that if the characteristic of a group affects its social position and you see a difference, then there's a disparity. But from a public health standpoint, we pick out race, ethnicity, socioeconomic, resources of social position, sexual orientation, and gender identity as some of the main issues for disparities. People with physical and mental disabilities are also recognized as disparity populations requiring special interest and special solutions. But conceptually, you could have disparities for other reasons, and I just wanted to give you that broader context. Disparities are not new. They were recognized before the 1980s, but the recent history of efforts to address disparities in the U.S. is usually linked to the Secretary's Task Force on Black and Minority Health, and this refers to the Secretary of Health and Human Services, who was Margaret Heckler. Her picture is there. At the time that this report was issued, there were 8 volumes addressing different issues, and obesity was noticed in terms of cardiovascular risk and specifically diabetes, and diet was also mentioned. Physical activity was not explicitly mentioned on this sort of modifiable risk factors list. So we've known that there are disparities in obesity for some time, before we recognized the epidemic in the general population. You could ask yourself then, what is it about the solutions we've been using to disparities that allows these disparities to persist and widen? And I think that's what we're here to address today. We have to be intentional in looking at, say, failures of our past approaches. What have we been focusing on? A lot of the work with minority populations has focused on cultural issues, not the context in which people live or the things that might be changed in the environment. We've also focused on socioeconomic factors. Some of that has been in healthcare access. Some of that has been educational solutions. But we have to ask ourselves today, what are we going to think about differently that might actually move the needle on disparities in obesity specifically? And if it sounds like something we've been doing for a couple of decades, it's probably not going to move the needle because these disparities have not gotten any smaller and some have gotten wider. So we want to, these are some principles that come out of the literature and some of my own work. We want to identify what are the ways that disparities can occur. Is it higher exposure to a certain type of risk? Is it greater sensitivity to that type of risk? Or is the risk the same, but when you try to change it, there's more pushback. It's more challenging to change. So that's just kind of a rule of thumb. So if the exposure is higher, you want to reduce the exposure. If the sensitivity is greater, you want to block that sensitivity so that people are not going to be disproportionately affected. And if it's context, you want to change the context in a deliberate way to address disparities. Another issue is to consider both ethnicity and SES, or socioeconomic status. I hope that people have stopped asking, well, isn't the ethnic risk, isn't that really only in the lower socioeconomic status groups? Because the answer is no. There's risk that comes both through the marginalization and difference and social disadvantage associated with being a minority, even when we become the majority, we'll still be minority in terms of political clout probably. And there's risk associated with poverty and education and housing, things that are related to socioeconomic status. Another principle, consider that one size does not fit all either within a particular minority population. Think about the 500 American Indian tribes or more. Think about the diversity of Hispanic or Latino populations in terms of their origins. And then across populations, certainly the issues are not the same. So even though it's handy to count everybody who's the other as the minority groups, we're really talking about many, many different populations. And we hope some of the talks today will reflect that difference, even though we couldn't go through every issue for every specific population. Also, for childhood obesity, consider the adult context. Vulnerability as a child or a lack of autonomy is a reason for taking certain actions, but what do we want from the adults who control the lives of children in high-risk populations? What is their situation, and how is that linked to the situation of the children? We can't leave that out. And then finally, use conceptual frameworks that have been designed to actually deconstruct the problems specifically in minority groups or in high-risk populations, or to construct solutions for those groups. There are several frameworks there. I'd love to spend the next hour talking to you about some of them, but just now to know that they're there, and perhaps some of the speakers will refer to those as we go through the day. So the rationale for targeted solutions, the impact has to be greater, because having equivalent impact will not close gaps. If we're just equally effective, we'll make everybody better, but the gap will be the same. So we have to be better. We have to accelerate with greater intensity, with greater focus. We also want to make sure that things are not worsened by solutions that we put into place. So disparities could worsen, actually, if we create a lot of solutions for the general population, but don't target and focus minority populations or high-risk populations. And the solutions we have are less appealing to the high-risk groups. They're less effective in the high-risk groups for a lot of reasons. They don't reach as many people. The effects aren't as large for reasons of the context. You know, it's harder to change things. It's not a good fit. Or there were unanticipated developments. I was noticing a quote on an article that just came out about decreases in sugar-sweetened beverage consumption. And the quote, I believe, from Marion Nestle was that it's too bad that companies might decide to make up for the decrease by targeting minority and low-income populations. You know, and that's the kind of thing. It's happened in tobacco, you know, dumping, you know, tobacco in communities or countries when you can't sell it in certain other countries. And so there are all kinds of unintended consequences. We can't assume that our solution is working in a static environment. It's dynamic, and when we get better at something, the opposition of whatever form might get better at it also, at what they're doing also. Just an example, these are the good news data that were put together in a Robert Wood Johnson Foundation brief about declining obesity prevalence in children. And you can see with an axis with the maximum at 50%, you can see promising small declines in that second time period across these different populations. Small declines that could signal that we're making progress. But if you read these reports, the original reports, the decline in Mississippi was in white children only. It was leveling off in black children, but it wasn't going down. In California, even though overall there were statewide decreases, it was not in all counties. Some counties were actually showing increases. In New York City, the declines were less in Black and Hispanic children and students in the high poverty schools. And in Philadelphia, the most significant declines were in Black and Hispanic children, and there were decreases in children from low-income families, but if you look more closely, the highest risk gender groups, the Black girls and the Mexican-American boys, didn't decrease as much as some of the other groups. So we have to be intentional, and we have to be very clever at figuring out how do we really get to the high risk, to the source, and fix that. So I'm going to review the report that we're basing our workshop format on. It's the Accelerating Progress in Obesity Prevention report that I mentioned before. This report has a vision of social transformation, changing society, where the environment is really supporting obesity prevention in a lot of different ways. This is what the sort of logic looks like. You would change things in governments and industries and in various environment and behavioral settings so that the default options were really healthier and more obesity preventing. People would respond to this individually and in the population. They wouldn't gain as much weight, or they would be better able to lose weight, and we would have the health outcomes we're looking for. For today's workshop and tomorrow, this is the but. We know that everybody's situation is not the same. So things like, factors like race, ethnicity, gender, socioeconomic status, and so forth are modifying our ability to achieve this vision. The 5 interacting areas that are the focal point for the workshop and the way that the panels are designed include these physical activity environments, and here's the goal, integrating physical activity, food and beverage environments, school marketing environments, messaging, school environments, healthcare environments, and work sites. So this is the organization of the recommendations in the APOP report, as we call it, and this will be the organization of our workshop. The idea is, in each of these areas, we have recommendations, but we don't know which recommendations are the most important for achieving equity, and we don't know what we have to do differently in implementing those recommendations. The report mentions the challenges of achieving equity, particularly in the food and beverage and physical activity and message environments, but today we're going to consider all of the environments. So I leave you, before I just talk a little bit about how the workshop is organized, with some questions that I'd like you to ask yourself as we go forward. What does accelerating progress mean when it comes to creating equal opportunities? Because it's accelerating, it's not just making progress, but how do we really speed it up? Which of the APOP recommendations are the most important, and why is that? And how can we tailor implementation for maximum effectiveness? What might be some gaps when we look at the APOP recommendations? Are there gaps that we need to fill in terms of addressing issues for creating equal opportunities? What evidence and stories do we have to inform action on the areas that we set as priorities, action of any type, new policies, implementation of existing ones, and what are some important steps, next steps for us to take? So that's just that's a question, some questions to think about as you listen to the speakers and as you make your comments from the floor. So what we're going to do with the format, we have 6 panels. That are the 6 areas if you split out the work sites and healthcare environments. Each panel has 3 speakers. The first speaker, it'll be a moderator. The first speaker will give an overview. The next speaker will have a case study related to the issue. Sometimes we'll have more than one case study. And after that's set, there'll be a discussion amongst the panelists to bring out some additional issues, but we've allowed an hour after every 2 panel discussions for a town hall when we expect to see you at the mic making comments. The town hall, the first 30 minutes will be presentations and questions from audience members. Then there'll be some public statements and a facilitated panel discussion to react to the public statements. So that's the way that we're going to go about this workshop. And without further ado, we will get started. I will turn this over to Jim Salas, who's going to lead the first session, which is called Physical Activity. How did I know? I don't have to look at my notes to figure that out. We'll go right into that first panel discussion.